I'll start off and I'll hand over to you for a couple of minutes and then we proceed.
Yeah, and then you introduce each faculty as they speak.
Yes.
Okay, good evening, everybody, and welcome to OrthoTV. For further proceedings, I'll hand it over to Dr. Warid. Over to you, Warid.
Yeah. Good evening, everybody. We welcome you all for this evening session on Ortho TV. And this time we are going to have a very good session on the basics and advances in the total elbow replacement surgery. Uh, we have a wonderful faculty from the United Kingdom. I'll be introducing them shortly. So I'll request Dr. Parag Sancheti to say a couple of words before I introduce the faculty. Sir.
Thank you very much, Dr. Warid. It's indeed a pleasure to welcome all of you for this unique webinar on total elbow replacement, which is being streamed through the OrthoTV platform. Total elbow replacement is still in its infancy in India, and we thought it would be a good opportunity to really popularize this surgery, which is much required, and the numbers of total elbow being replaced in total elbow replacements being done in India are far, far less than what is actually required. So I take great honor in welcoming this absolutely top of the line faculty. For this, I want to thank Dr. Shantanu Shahane, whom I called up a couple of weeks ago, and I asked him, can he really hook us up to Professor Stanley? And he immediately agreed, and he himself, being also an authority, is a faculty today. So I want to thank Dr. Shantanu Shahane for putting this webinar and helping us to get the top of the line faculty, Professor David Stanley, and also Dr. Amjad Ali. So thanks to the UK faculty, and Dr. David Stanley, as all of you know, is the father of total elbow replacement and is considered as a doyen in total elbow replacements. We know that, Prof, and we are eager to hear you today. I also want to thank Dr. Amjad Ali for joining, and we will be happy to hear his experiences. Of course, Dr. Gautam, I had the pleasure of meeting just about 10 days back when he did the first elbow replacement at Sancheti Hospital. He did a great job, and a very humble guy. And of course, he has to be good because he's trained with Prof. Stanley and Dr. Shahane and with Dr. Ali. So welcome, Dr. Gautam, and we look forward to hearing from you. I hand over back to Dr. Warid, who will take us further. But before that, I want to thank Dr. Warid for organizing this webinar and coordinating the whole show, and also Dr. Chetan Pradhan, our own faculty, who is a master in fixing all kind of difficult fractures and has a special interest in elbow fractures. So welcome everybody, and I look forward to a very exciting 1 hour ahead and learning more about total elbow replacements. Over to Dr. Warid.
Thank you so much, sir. I would like to thank Dr. Parag Sancheti, who has been actually behind all this in organizing. I've just been a part of it, but it's Dr. Parag who has organized all the faculty, put on this very good program, which we'll be having now in the next 1 hour. So I'll just share my small presentation on our faculty of for today. So we have Dr. David Stanley. He's trained in Sheffield and is working as a consultant in the upper limb surgery in Sheffield since 1991. He has a special interest in elbow surgery. He has more than 50 peer-reviewed papers, majority of them being on elbow disorders. He's a previous president of the British Shoulder and Elbow Society, that is from 2007 to 2009. He's a member of the European Society of Surgery of Shoulder and Elbow and American Shoulder and Elbow Surgeons since 2010. He has co-edited 2 textbooks on elbow, and the largest being The Elbow Surgery. All of us know that it's a favorite book among the elbows we read. Is the honorary secretary of the British Orthopaedic Association from 2010 to 2013. He has represented British Orthopaedic Association at the European Board of Orthopedics and Trauma, and he has been an examiner for the Intercollegiate Examination Board in Trauma and Orthopedics for 10 years, followed by chairman of the examination board. And he's currently the editor-in-chief of journal Shoulder and Elbow. I welcome Dr. David Stanley. Thank you so much, Dr. David, for joining us in this webinar. Our next speaker will be Dr. Shantanu Shahane. He's a consultant in general orthopedic and upper limb surgery. He's qualified from India, Pune, in 1989. And following this, he went to UK, and after 6 years of training, he was awarded FRCS in orthopedics and traumatology, and also successfully completed MCH in orthopedics from Liverpool. He has a special interest in shoulder and elbow surgery and electively deals only with the cases pertaining to the upper limb surgery. And he has special interest for primary and revision shoulder and elbow replacements. He's a member of British Elbow and Shoulder Society and instructor in the British Orthopaedic Association for various courses held across country. In 2014, he was awarded the British Elbow and Shoulder Society Fellowship to represent UK in World Shoulder Congress in Japan. He is reviewer and associate editor of the journal Shoulder and Elbow. Extensive list of publications and book chapters, and heavily involved in training budding orthopedic surgeons in numerous in national and international courses. I welcome Dr. Shantanu Shahane. Thank you once again for joining us in this webinar, sir. Our third speaker is Dr. Amjad Ali. He is graduated from the University of Sheffield in 1996. He undertook specialist shoulder and elbow training from Sydney, Australia, and Northern General Hospital in Sheffield. He is specialist in elbow and shoulder disorders, and significant part of Dr. Amjad's work involves treating complex shoulder and elbow injuries. He has a special interest in revision elbow replacement surgeries and has designed a set of instruments which are used in revision elbow arthroplasties. He has published numerous papers in all the renowned journals we all know, that is the JBJS, the Journal of Shoulder and Elbow Surgery, the European Journal of Orthopaedics and Traumatology, and he's also an examiner for the Royal College of Surgeons Fellowship Examination in Trauma and Orthopedic Surgery, Deputy Training Program Director for the Yorkshire and Humber region, and Clinical Director of Musculoskeletal Services in Sheffield. I welcome Dr. Amjad Ali. Thank you so much for joining us, Dr. Amjad. And we have a very well-known panelist, Dr. Parag Sancheti, who's chairman and orthopedic surgeon of the Sancheti Institute in Pune. Dr. Chetan Pradhan, he is a trauma surgeon who deals with all the complex upper limb surgeries. And Dr. Gautam Tauri, who is an upper limb surgeon specialist in shoulder and elbow. And we will be having a discussion after we have the speakers have their talk. Thank you all. So I'll stop sharing the screen. So I welcome all the faculty, and I would hand over to Dr. Shantanu, who will be starting his first talk on the basics of total elbow replacement and all the biomechanics and basics surgical approaches related to it. Dr. Shantanu?
Can you see my screen?
Yes, yes, absolutely.
Okay. Ladies and gentlemen, good afternoon, good evening. It is just past 3 o'clock in the UK, and I think it is just short of 9 o'clock in India. So we welcome you. Thank you for giving up your time to listen to us. It's quite late in the night. We'll try and make it as entertaining as possible for you. So I work primarily adult practices in Chesterfield Royal Hospital. My pediatric shoulder and elbow practice is in Children's Hospital, and I do some work for the University of Sheffield. I just thought I have the main talk that I have today is about total elbow replacement in trauma. Having been worked in India for so long, I understand trauma is a very important part of orthopedics in India. And therefore, I think it's an important thing to understand what is a small but a definite indication of total elbow replacement in trauma. But I think before I start that talk, and excuse me if this sounds very basic, but I thought I'll just set the scene for what is total elbow replacement, what do we do in UK, just very, very simple things, 5 or 6 slides before I go on to my main talk. So people who are shoulder and elbow surgeons might think the first 6 slides is very basic, but please bear with me for the general orthopedic surgeons amongst us. So the primary indications for elbow replacement remains rheumatoid arthritis. We don't see as much rheumatoid arthritis in India, and primarily whatever arthritis we see in the elbow is probably osteoarthritis. Though having not been in India for the last 26 years, I'm not sure if the trend has changed. Of course, the trauma is different, and I will talk about the acute trauma and distal humeral fractures, but obviously post-traumatic arthritis, which is symptomatic, also forms an important part. In UK, we don't deal with tumors. They go to specialist tumor centers. And if somebody needs a custom-made prosthesis for a localized malignancy or a localized METS, then it'll go from us to sort of somewhere like Birmingham for a tumor center. But I just thought I should put that on for you. Now, When I joined Sheffield Rotation in the mid-90s, David Stanley was the consultant there. I was his registrar at that stage. And we were seeing a lot of this kind of x-rays. And I was quite amazed because having come from India a few years ago, I never saw this extensive arthritis where not only were patients in pain, but they had very limited mobility. And as you can see, this elbow, for all practical purposes, looks ankylosed. And we then found out the reason being the Sheffield was the steel making center of the country. And those days, in the lack of mechanization, there was a very high amount of upper limb and especially elbow involved manual labor. And people in their 40s and 50s were getting this kind of elbow pathologies. Obviously, nowadays with mechanization, we see this, if at all, in more than 60 years, they complain of pain and stiffness. And it is important to understand that not all elbows who look like this will be symptomatic. A lot of them will have limited mobility, but they'll cope because you as well know that only a certain amount of mobility, 30 to 130, is needed for functional use of the elbow. And therefore, please understand that if an elbow looks like that, it is not an indication for elbow replacement. More often than not, conservative options are okay. Occasional painkillers, you don't need physiotherapy for this, it doesn't help. An OK procedure is something I had never seen before I came to the UK quarter of a century ago, and it's a very effective procedure. And obviously, total elbow replacement remains your last option. Now, how do you decide when do you do an OK procedure? And I will describe what that procedure is. And when do you do an elbow replacement? So the way I say it, if you have end range pain, extreme extension and extreme flexion, then an OK procedure works well. Because all it does, it takes away the osteophytes from the front and the back. But if you have through range pain, where throughout the range of flexion movements you have pain, then I think OK procedure is unlikely to work because it's not just the front and the back which is a problem. Throughout the range of motion is causing pain. So I think that's a very simple tip to take away, which one to do: through range pain and end range pain. OK procedure is very straightforward procedure. You go from the back, you go through a tricep split approach, you excise the capsule, tip of olecranon and the osteophytes, then you create a hole from the back of the humerus to the front compartment and excise the tip of the coronoid, anterior capsule and loose bodies. Once somebody has shown it to you, it takes about 20-25 minutes to do. It's a very effective procedure in the right selected patients. And if you have ulnar nerve symptoms in the patient, you can do a cubital tunnel release at the same time. So this is a classic patient who has osteoarthritis. You can see a nice olecranon spur here. That's his native olecranon here. This whole thing is the spur. And in the front, you can see large bits of osteophytes. So you basically, in OK procedure, go from the back through the tricep split approach and remove all this. Then you make a hole from the back to the front. We use a trifine that we use for bone biopsies. And then you remove all the stuff from the front of the elbow. And the post-op X-ray looks something like this, where you can see the extra tip has been taken away, everything in the front has been taken away, and the patient gets reasonable pain relief. It's very important to tell the patient after OK procedure that you may not necessarily get a great deal of movement improvement, but you will get the end range flexion and extension impingement pain improvement. And this is something which a general orthopedic surgeon should be able to do. You do not need to refer it to a specialist center to have it done. This is the more common indication of arthritis in the elbow in UK. It usually comes in a young age, pain and stiffness. And the disease-modifying drugs these days are so good that we now see routinely elbows which are absolutely shattered and destroyed, but they have very little pain, in which case they don't need an elbow replacement. And radial head excision is not something we do in osteoarthritic patients, but in a select group of people, synovectomy and radial head excision does work. And if nothing else, it at least postpones the inevitable need for an elbow replacement. So this is a classic rheumatoid elbow, and the answer here is elbow replacement. I would not do an OK procedure in rheumatoid arthritis unless it's a burnt out rheumatoid resulting in osteoarthritis. So OK mainly for osteo, and radial head synovectomy as a stopgap for rheumatoids, followed by elbow replacement in both cases. There's a lot of debate which type of elbow replacements you should use and what kind of classification you should do, constrained, unconstrained. The way I was always taught was to say they're either linked or they're unlinked. And this is the one which I think Dr. Tiwari uses in India. And I think 75% of the elbow replacements that are done around the world are the Kundan-Mori elbow replacements. All three of us, myself, David Stanley and Amjad, use Kundan-Mori elbow replacements. Unlinked are the ones which don't have a link in between, and Kudo was the old favorite. I have not a great deal of experience in Kudo, I must admit. And what approaches do you take? Tricep splitting, which is a well-known approach. Reflecting is better because it preserves the integrity. And I use, and most of our colleagues in UK for intra-articular fractures will still use an osteotomy approach. Myself and David Stanley wrote up a paper in 1999, British Journal, and we formulated this Stanley-Shahani approach. And the big advantage of that, it combines the advantages of splitting and reflecting techniques. And I'm very pleased to say that a lot of UK centers now use this approach. And if you do want to read about this approach more in detail, then you have to just type in these two names and see 1998 British Journal JBJS. The advantage of this is that it protects the ulnar nerve, gives good exposure, and really provides a good tensioning for stability. I won't go into the details because that's not the topic under discussion today. And that is all. I want to set the scene in 5 minutes. We know what the indications for elbow replacements are. We know what other procedures we can do other than elbow replacements and what approaches and how you classify elbows. I will now spend the next 8 to 10 minutes in describing elbow replacement in distal humeral fractures. Now, this will be very, very useful to even to primarily a large number of trauma surgeons in the UK. And India. Trauma surgeons in the UK who are not elbow specialists will still do this operation, but you need to be aware of the pitfalls, and Dr. Ali and Dr. Stanley will speak about it later. Please understand, if you have an intra-articular distal humerus fracture, the answer is not elbow replacement. The answer remains open reduction and internal fixation. There is no doubt. But once you do this, if you don't do it properly, or even if when you do it properly, numerous reviews have said the complication rate can be quite high. But this complication rate includes removal of metalwork, and especially the tension band wiring of the olecranon. And therefore, I think the complication rate has been skewed by removal of metalwork. And if you take the removal of metalwork out as a complication, to me, it is not a complication. But yes, it is a definite second operation. But we know that even if you do the best possible operation and use the best possible implant, the outcomes in elderly patients are not great for internal fixation. I'm going to show you a historical X-ray. This was one of the first patients I saw when I joined as a consultant nearly 20 years ago. And this is a straightforward distal humeral fracture. And this is how I fixed it then. I used recon plates, had some real struggle bending these plates. We had some headless screws here. I was still using this particular cancellous screw to fix the intra-articular fracture. And the patient had a good outcome. It doesn't look very pretty, but it did the job. And as you can see, I did an olecranon osteotomy. Now, if I have a fracture like this, my answers are not 90-90 plating. It's parallel plating. These are contoured. We follow all the principles of trying to get as many screws across as possible. But one part of my technique has not changed. I still do an olecranon osteotomy to get a good exposure. And I will continue to do that. And normally you would expect this kind of a range of motion. I think if done properly, you get one good shot at it and therefore do it the best you can. But why is it a problem in the elderly? Well, bone quality is poor. Usually when they fall, they really shatter the bone. There is loss of joint fragments. And some of them have pre-existing arthritis. And then some of them come with contractures and bony deformity. So this is not what you see in a 30-year-old who breaks his distal humerus. So therefore, what are our indications for an elbow replacement? The age has to be above 65. I prefer even beyond that, 70, 75. But sometimes you may see a 65-year-old who is physiologically older, has severe osteoporosis, and you think this fracture is not fixable. Don't try and fix it to convert it into an elbow replacement in 6 months. Take a decision right at the early, and I'll tell you how to make that decision making. So this is a comminuted fracture in an osteopenic bone, which is not amenable to stable osteosynthesis. And to me, this bit is an absolute indication. If somebody tells you that he had, before fracturing his distal humerus, in a lot of pain because of pre-existing inflammatory joint, then don't try to fix it. Because that joint would not have been mobile before. You're trying to fix immobile joint, and the transfer of forces will happen across the fixation, which at best is tenuous in an osteopenic bone. So I think that is a good indication for a primary elbow replacement in distal humeral fractures. What are the contraindications? Please don't replace an elbow replacement in a 27-year-old. He comes, send it to somebody who can fix it properly. Compound fracture, poor skin condition, active infection, obviously you wouldn't dream of doing anything there. Olecranon fracture is a relative contraindication because otherwise the proximal ulna has no support. Though you can fix the olecranon and replace, I have no experience in that. And I wonder if my other co-authors have any further experience in that. What are the type of prostheses? We have just told linked prosthesis. Why do we need a link? Because these fractures have a lot of bone loss And they have lost two important stabilizers. They have lost the static stabilizers, which are the ligaments, and there is a significant damage to the muscles. And therefore, inherently, they have very little stability of their own. And therefore, you need to put a link in between to provide the stability due to the lack of these things. And the prosthesis of choice for us is this Kundal-Mori prosthesis, and that's the link we are talking about. So that links these two and provides the stability, which is axial and varus valgus stability. It allows early mobilization, and this anterior flange that you can see provides rotational stability. It does not disassemble and is very user-friendly. Once you get used to it, a straightforward operation is not difficult, trust me. And it has very, very good results in long term. You can see these bushings here. They can get worn out though. Polyethylene bushings can get worn out. And sometimes you just go into a bushing replacement. So what are the preoperative conditions? Before you take a patient to theater, please decide whether you're going to do this or you're going to do this. Fix it or replace it. Because normally these are difficult fractures and therefore you're going to do an olecranon osteotomy. If you do an olecranon osteotomy, you don't want to be doing an elbow replacement. So don't say, I will decide this intraoperatively. Normally, I will say, get a CT scan done, discuss with your colleagues and decide which way you're planning to go. Look out for a supracondylar extension and be careful that you have all kinds of lengths of humeri available if you want to bypass the supracondylar extension. Please be aware, if there is a shoulder prosthesis and the tip of the stem is coming down, that you don't reach halfway through and say, oh God, I've hit the stem in the canal. I can't go any further. And please look out for canal diameter. Especially in India, Asian ladies will have very tiny medullary canal. So be very, very careful that halfway through the operation, you don't reach a stage where you can't put the humerus or the ulna inside. So be aware of all of these things before you embark on the surgery. These decisions have to be done before you enter the operation, not during the operation. The technique we use is lateral decubitus, central midline approach. We always decompress the nerve. We don't routinely transpose it anteriorly like some of the Americans do, and we use our own designed approach. It's very straightforward. I'm just putting it in one line. You basically excise the entire distal humerus and bend it and put the humeral and the ulnar components. We always use the cemented humera and the cemented ulna. Post-operatively, I have started putting elbows in extension because the big problem here is the skin condition over the olecranon is not great. And if you put it in flexion and the immediate vascularity of the skin goes, then you start getting a little bit of a dehiscence of the wound, and then that becomes a superficial infection, then it becomes a deep infection. It is just not worth it. Let the elbow heal. Getting mobility in a linked elbow is not a problem. And then start gentle flexion with extension night splint for the next couple of weeks. Discard the splint in 2-3 weeks. Once the stitches are out, the wound is healthy, you can go for the physio. These are my requirements, and we normally say to people that once you've had an elbow replacement, to increase the longevity of elbow replacements, don't carry more than 5 kilograms of weight at one time or 1 kilogram repeatedly. Try not to use crutches, easier said than done. Don't use body weight on the elbow, and golf can be a no-no because it transfers a severe amount of stress during especially the driver phase anyway. These are complications. I don't want to go into this. This will be dealt by my other two speakers. Review of literature. So Mori's clinic produced this first paper in 97, where they saw 20 patients, mean of 72. They followed them up for up to 10 years, and they were really, really good outcomes because they had selected the patients well. And then there is a lot of literature that is available. Joe Garcia is one of my colleagues in Chesterfield with David Stanley in UK, produced their first experience in 2002, and they had very good outcomes. All the 3 UK authors, I'll come to that in a second, the Canadian Orthopaedic Association then produced these results again in October 19, which were very, very favorable. And all of us 3 authors then wrote this paper in Journal of Shoulder and Elbow Surgery. And we had 26 consecutive patients. Look at the age range here with community distal humeral fractures. And at 5 years, we had very, very good outcomes. This is something that was fixed and sent to me. I could see this was not going to work, and predictably it went into this, and I think the elbow replacement was the right answer. This was in my very early days, and you can see this length is not enough, and there is a huge supracondylar extension, and this prosthesis failed. And I had to then revise it to a long stem. It was a real salutary lesson to me why this supracondylar extension that I was talking to you about is very important, because there is very little stem beyond it. So just be careful of this. Now, if you see this in a rheumatoid patient, completely shattered, it is beyond me to fix this. You can, but I think it will fail. And therefore, I have no objection in doing this as a primary replacement. This particular patient developed a lot of myositis, which I think Amjad and David will speak about, and eventually lost some movement, but she was very, very happy with the outcome. One operation that gave her independence back to her. And I will finish on an amazing case. This is a 78-year-old lady who came to my clinic in 2017. She didn't directly come to me. This was the kind of fracture she had. And my colleagues, I was on holiday, treated this in a brace for first 6 weeks. There is zero chance of this healing. And then at 3 months, they continued and no different, exactly the same. And this lady had rheumatoid arthritis. You can see the joint space really narrow, poor elbow function before. And to me, this is the definitive answer for her. A really long stem, and I've not done the same mistake. It's coming till here. I've gone overboard completely. I've said, let's neutralize the entire humerus. This is one of my happiest patients because you have given her life back because she had a pseudoarthrosis halfway through. So total elbow replacement is a good option. It is very appropriate patient selection. Be careful of what can go wrong. Use good surgical techniques, but please remember, it is not an answer for everything, and internal fixation remains the gold standard. Thank you very much.
Thank you so much, Dr. Shahane. That was very crisp about the basics of the total elbow replacement. I think we'll continue with the further talks, and then we can have the discussion in the end of all the talks. So I would like to invite Dr. David Stanley and Dr. Amjad Ali, who both will be talking on the complications of total elbow replacement and the revision elbow replacement. So Dr. David, you can start sharing your screen.
Well, thank you very much indeed for the invitation. I'm really just going to outline the common complications, and then I'm going to let Amjad talk to you about how he deals with them. So the complications that tend to occur are aseptic loosening, instability, joint infection, which can be early or late, and then there are tendon ruptures that occur particularly associated with the triceps. So if we look back through the literature to Geschwendt's paper in 1996, when he looked at 828 arthroplasties that had been done between 86 and I think it was 92, I can't quite see that on my screen, he noted that all complications from elbow replacements totaled up to 43%, which was really quite a massive complication rate in the literature. And then when Mori then looked at a similar thing, but with a much larger number of arthroplasties, 2,938, the complication rate had fallen to just about 24%. And I think that is partly because the experience in doing elbow arthroplasties had improved. And I think as well that the implants that were being used during Mori's survey were better quality. And we can talk about the types of elbow replacements and historical aspects of that if we have time. So what do we see when we look at them and compare these two studies? Well, I mentioned that Geschwendt had a 43% total complication rate when he looked at all the studies he reviewed, and Mori's was down to 24%, nearly half. But it's interesting to note that the commonest three type of complication were exactly the same: aseptic loosening, instability, and infection. And in addition to that, you need just to be aware that the ulnar nerve can be damaged when you do your elbow replacement. And Mori noted that if you transpose it, you had a smaller ulnar nerve risk than if you didn't transpose. Shantanu has already told us that he tends not to transpose the ulnar nerve. I also tend not to transpose the ulnar nerve. And again, in the discussion time, we can talk about why we do or we don't transpose the ulnar nerve. If we have the time to do that. So if we look at and compare unlinked with linked implants, the overall loosening rate, when you look at the information within the papers, is very, very similar, about 5%. But when you look and try and identify in greater detail, you discover that actually if you look for clinical loosening, which is obviously a late stage problem, but then include radiolucent lines 1 millimeter or more in size, or a shift in the implant position, you actually find that unlinked implants do slightly better than linked implants. And this was in Mori's paper in 2011. And Mori, of course, uses a linked implant, the Conrad Mori implant. But he was honest enough when he reviewed his work or the papers to notice that actually linked implants had a slightly increased rate of aseptic loosening. So how does that happen? This is an unlinked Kudo implant. This is the same patient over several years. And the X-ray on the far left of the screen looks really very acceptable. The position of the implant, the humeral and ulnar components look absolutely fine. But over time, what happens on all humeral implants, it doesn't matter if it's a Kudo, a Conrad Mori, or any other type of implant, the humeral implant will always tend to rotate such that the tip of the implant comes forward. The lower end, the articular end of the humeral component will tend to go backwards. And you see it here, and you see it here where it's almost broken through the anterior humeral shaft. Now, if you watch it like this was, it happens. Once it starts to happen, you need to do something about it because otherwise it will only get worse. So when you see a humeral position, humeral implant position changing, you need to seriously start talking to the patient about the fact they need a revision. On the ulnar side, the loosening tends to occur in an antero-posterior direction. So you get this windscreen wiper effect where the implant is moving in an antero-posterior direction and causing damage to the intermedullary bone. And again, if you leave that, it will eventually fracture through the ulna and your revision surgery will become much more difficult. So how do we think about aseptic loosening? Well, if you've got an early failure and you think it's aseptic, then I would suggest that you actually exclude infection, because one of the commonest causes of early failure is infection. So you may think it's aseptic, but you need to prove that by doing blood tests and a joint aspiration. Early failure occurs if you've got a poorly positioned implant or if there's impingement occurring. And by impingement, I mean that the implant is impinging on the patient's own bone during flexion and extension. And when that happens, you'll get a force that tends to break up the cement bone interface, causing the implant to become loose. When you see a patient that's had their implant in for some years, and again, it appears to be aseptic, then I would again suggest that you exclude infection, because again, late infection can be a problem. If infection is excluded, then you need to look and think about why this is getting loose. And it's usually because there's a failure at the bone cement junction or because of polyethylene wear. So when we moved on to instability, unlinked implants, of course, must have a much higher rate of dislocation than linked implants. But linked implants can still dislocate. But as you can see here, the difference in frequency is much less. But linked implants have problems with bushing wear and disassembly. This is a Kudo implant that's clearly dislocated, and that's going to need almost certainly a revision. You can try and do a soft tissue reconstruction, but nearly always they need to be revised. And this is a Geschwint implant, and this is a linked implant, and the tip of the ulnar component should be in the middle of the humeral component here, but that's become dislocated. And the normal reasons why this type of situation occurs with linked implants is because the soft tissues haven't been balanced at the time of the primary surgery. So you must make sure that the elbow is stable, whether it's a linked or an unlinked implant, at the time you close the wound. And this is 3 different patients with a Conrad Mori implant in place. And what you see here is that the pin, and this is a pin within a pin, the pin within the pin has started to come apart from each other, and you see it in this patient as evidenced by the pin position not being snug up against the humeral component. This is a separate patient, but if you left this patient like that, then you'd start to see the pins bending. And finally, a third patient, but again, if you left this patient, this would happen where the pin actually breaks. And when you do a revision, you see this. So this is a normal pin, and this pin here should go inside this pin. But what you find when the flanges here break, you end up with the loss of the flanges because they've broken, and then this can slide out of here, and you get this polyethylene wear occurring. Infection, Geschwint noted a 9% infection rate. The more recent studies by Mori, and I think my own experience would be that the infection rate is actually lower now. And certainly when Mori did his review, it was down to 1/3 of the Geschwint infection rate. But you need to be aware that the modern anti-rheumatoid drugs do increase the risk of infection. So anyone on a disease-modifying drug who's starting to have problems with their elbow, do think about infection, because it can be a problem in that situation. I think Amjad's going to just talk about some of these things here, but if you debride an infected elbow, you have about a 50% chance of curing the infection. But Amjad, I think, will tell you that in fact, if you do that early, you probably do better than that. If you do a single stage revision, it's about 33%. If you do a 2-stage revision, and sometimes you may need to repeat the first stage if you can't be sure you've done a good enough initial debridement. But if you do a 2-stage, it comes down. And if you literally take out everything, take out all the cement, take out the implant, and do a resection arthroplasty, the infection rate, recurrence rate is very small indeed. And the last thing I really just need to say to you is just to think about triceps complications. Probably higher than 2 to 3%, probably underreported. And treatment options, you may be able to do a primary repair, or you may need to do some of these other things like an anconeus rotation flap using an Achilles tendon allograft or hamstring, or a ligament augmentation to repair the triceps. You do need to have a functioning, well-secured triceps if you're not going to run the risk that an elbow replacement may become loose in the future. So in summary, 2 different studies looking at different numbers of elbow replacements, but interestingly, aseptic loosening, instability, and joint infection remain the top 3 types of complication. And I've put in about tendon ruptures just to remind us all to check the triceps when we've done an elbow replacement. So thank you very much indeed.
Thank you, Dr. David. I would like to request Dr. Amjad to continue with the complications and his talk on the revision elbow replacement. Sir, you need to unmute yourself. Yeah.
Bottom left of your screen, Amjad.
I know. I was just looking for it. Thank you very much for that helpful advice. Right. Sorry about that, everyone. It's nice that one person gets it wrong anyway. Thank you very much for the panel India for inviting us to do these talks. And I hope you find this talk useful, although I must say one of the reasons why I'm giving this talk is in a way to not scare people, but to say always think twice before you do an elbow replacement and make sure it is the right thing to do for that patient, and pick your patients. Otherwise things can go drastically wrong. So first of all, the main reason for revising an elbow is loosening, usually of the implant. And what you need to do is make sure you exclude infection. So infection, you have septic loosening, and where there's no infection, you call it aseptic loosening. And the treatment is very different, and the outcomes for the patient can be very different as well. So you need to make sure, and as Dr. Stanley has said, exclude infection. We had some guidance from the British Elbow and Shoulder Society on this through the Shoulder and Elbow Journal, which many people contributed to, so that's worth reading. So what are the causes? Causes, Dr. Stanley's already mentioned. Contamination during the initial surgery can come from local soft tissue infection and hematogenous spread. So if it's early on, it's likely to be due to contamination during surgery, but if it's later, it can be hematogenous spread. And they can be extremely difficult to manage. First of all, the diagnosis can be difficult. Secondly, the soft tissues can be very poor, especially if they've had repeated surgery and debridements. Thirdly, the bone stock is affected because you get dissolution of the bone around the implant. And sometimes with the debris, it causes more osteolysis. And ultimately, the implant options become difficult. I think once you've done one elbow replacement, followed by a revision, followed by another revision, your options become extremely limited. So the poor soft tissues, you can see here 3 examples, and these are because these patients have had repeated surgeries. And you can imagine trying to go back into an elbow like that can be extremely risky, and risking amputation. So if things go wrong after that, you have to warn the patient that actually they could end up with an amputation. Fortunately, fingers crossed to this day, I've never had to amputate an arm for complication of an elbow replacement or elbow revision, but I'm sure that day will come. Like I mentioned, bone stock can be a problem, and it can be due to infection, it can be due to wear debris, it can be due to fracture or general aseptic loosening. So the crucial thing in the diagnosis is the history. We always teach medical students, you must take a good history, and it applies in complex and very subspecialized clinical scenarios as well. So take a good history, ask about any infections around the time of their initial surgery, any infections since, any time that their general practitioner may have given them antibiotics for a possible wound infection. You need to take some radiographs and do some routine blood tests, including the inflammatory markers, and also perform an aspiration or open biopsy. With the aspiration biopsies that we tend to do in Sheffield, you have to make a small skin incision, prep it fully, and put the needle in through that skin incision. Otherwise, there's a risk of contamination from the skin. Some of the centres would advocate open tissue biopsies to send for culture before the revision is carried out. We published this paper recently in the JSES, looking at over 100 elbow revisions, but we looked at over 60 single stage revision operations where we performed just blood tests, aspiration and x-rays, and based on these patients underwent single stage revision, and we found that actually it was safe to do it that way. But if you're worried at all and you think there may be an infection and the aspiration comes back negative, do an open biopsy. The only thing with open biopsies I would have to say is that the tissue you actually want to get for the culture lies in that area that you see. So doing a soft tissue biopsy from this area may not give you the answer. And if you're worried about infection, I would rather do a first stage revision, take the implants out and debride it, and then go back to do the second stage revision if all the cultures come back negative. So ideally, you want to make sure there's no infection before you go in to do this first stage, to do the single stage. So always remember, the treatment has to be individualized for that one patient. This isn't a one size fits all. You have to take every patient separately and talk to them honestly about the risks, because some of these patients will be frail elderly patients with poor soft tissues, and you need to make sure they understand what the implications are of further complications with their elbows. And always respect the patient decision. If they have an infected elbow and they're not unwell and they're happy to take lifelong antibiotics to suppress that infection, then you may have to go down that route. So never force a patient into having something done. Early involvement of a microbiologist is crucial. And here in Sheffield, we're very lucky that we've got one of the world-renowned microbiologists who has a specialist interest in implant infections working with us. And he's always very helpful, even when he's on holiday, as I phoned him a few days ago while he was on holiday for some advice. I apologise, but actually I think he was still happy to give it. So there we are. So, and the other thing is, post-operatively, you need to have specific rehab. Not all these patients can start moving their elbows straight away. And as Dr. Shahani mentioned, he puts his in a back slab or some sort of splint to rest the soft tissues. I put them in a very bulky bandage and a collar and cuff sling because some of them find the plasters too heavy, and I advise them not to fully flex their elbows until the wound's healed. So what type of revision should you do? Should you do a DARE, or should you do a single stage revision or a two-stage revision? A DARE, for those of you that may not be familiar with this, is a debridement, antibiotics and implant retention. So this means effectively you're debriding the joint and leaving the main components in place. So the indications for this are usually the infection has to have occurred less than 3 months following the initial implant insertion. The symptoms should be less than 3 weeks of onset. The implant should be well fixed. And if there are acute onset of symptoms where the implant's been in for a few years, but the symptoms have only started a couple of weeks previously and the implant is well fixed, you could still perform a DARE procedure. So the procedure is always open, it's not an arthroscopic procedure. And withhold any antibiotics until the samples are taken at the time of surgery, unless the patient is unwell, where you could do blood cultures and start them on antibiotics. When I'm taking these samples, you always use a fresh blade for each tissue sample that you take, otherwise it risks contamination. And usually the reason why you take 5 samples is because it's an odd number, and you can go on the best of 5 depending on how many come back positive. So you always perform a thorough debridement and a washout, exchange any modular components. So with the Coonrad Mori, you would change the link pins that have already been shown and the polyethylene. If the soft tissues are very bad, involve the plastic surgeons. It's very rare that you actually need them, but occasionally they may need to do local flaps, or in some cases, I've had plastic surgeons doing vascularized flaps at the time of the revision. So I'm going to show you this because this is how not to do a DARE procedure. So this patient had an elbow replacement somewhere else and became infected quite soon after the operation. And someone phoned me and said, would you mind having a look at this? And this is how she came across. So if you're going to do a DARE procedure, do it properly or send it somewhere where it's done more frequently. So post-operatively, antibiotics until you know the microbiology, and then ask your microbiology for advice on which antibiotics to continue not long term, but in the short term, and usually it can be anything from 6 to 12 weeks. So that's a DARE procedure. Single stage revisions. I only perform them for aseptic loosening. I always consent the patient at the time to say that actually if we go in, we may find there is evidence of infection, in which case they will just have a first stage revision. So we'll take the implants out and debride it. And I don't do single stage revisions for infection. I know there is a change in the lower limb arthroplasty world with regard to doing single stage revisions for infection, but as yet in upper limb, we try not to do this, and I certainly wouldn't do it for elbow replacements. So again, the investigation is much the same. It's blood tests, radiographs, aspiration, and if the aspiration is negative and the blood tests look fine, then I would go on to do a single stage revision. You can do a single stage revision for unstable, unlinked implants if you have the revision implants in your hospital. If you don't, sometimes you need to have custom made implants, in which case occasionally I have done a first stage to make sure there's no infection, to take the samples and then do the second stage at a later date. I always say plan ahead. This isn't something you do with a week's notice. You need to make sure you have the adequate theatre time. These procedures can often take hours. Last week, I did a single stage revision, which took 5.5 hours. Some people may call me a very slow surgeon, but unfortunately, that's how long it takes. You need to have the appropriate staff in theatre, people who are experienced in doing arthroplasty surgery. You need all the kit available. What you don't want to be doing is be stuck halfway through the operation and to then have kit transferred from another hospital. Again, withhold the antibiotics until the samples are taken, and again, send at least 5 samples. This is just a couple of pictures of some revision instruments we use, and I'm quite proud to tell you that the one on the left-hand side is something I designed when I was Dr. Stanley's junior doctor, 2 years after qualifying from medical school. So he helped me with that. So thank you very much. And the ones on the right are some very fine osteotomes and specific instruments he designed and had made by one of our local companies in Sheffield. So again, I've mentioned the previous things there with the planning and the staffing. And I would withhold the antibiotics again until the samples are taken, perform a thorough debridement, remove all the cement and all the membrane as well. So you'll all have seen x-rays where there's cement inside the bone, but there's a lucent line even on the immediate post-op x-rays. And often that's because the membrane hasn't been removed fully. So the cement can't integrate and doesn't bond to the host bone. And when you re-implant the implants, you use Corpal cement, which has added antibiotics. Always chase the 14-day cultures and discuss any positive findings with the microbiologist. So with an unstable implant, you can see here, Dr. Stanley's already shown you the Kudo implant. These can become unstable, and I think trying to stabilize them using soft tissue procedures usually fails, because these patients are usually rheumatoid, and we know that rheumatoids have very poor soft tissues. So I chose to revise this to a linked implant, which is a Coonrod-Mori. Sometimes you get x-rays like this, where one of the components is completely loose and the other one's well fixed. Unfortunately, the reason this implant failed was we found at the time of surgery that there was some cement actually jammed inside the bearing of the implant. So I think from day one, the humerus has always tried to loosen. And the problem here is this implant isn't widely available. And in my opinion, it's not a great implant because the two parts of the implant can disengage relatively easily without the soft tissue stability. So we had to revise this fully to a Coonrod-Mori. So if the implant is no longer available, you have to change the whole implant for a new one. Then you can get cases where the humerus is well fixed, and as you can see, this is already a revision procedure, and to have a long stem humeral implant, and there is loosening of the ulna secondary to a periprosthetic fracture. And again, with these, this one required allografting as well with a very long custom-made implant. And this lady to this day is doing reasonably well. And you can see she's rheumatoid. She's had previous she's had previous fusion of her wrist also. This case, again, this is a discovery implant, and looking at these x-rays, the loose bits of bone are actually chronic. They've been there a long time. But one thing you'll notice on this x-ray is that screw in the anterior part of the joint. I thought this may well be the screw that holds the implant together. But actually, this is a clinical photo. When we did it, there's extensive metallosis. So as soon as the incision was made in the skin, you can see how the metallosis bursts out. And following the debridement, the picture on the right shows this. But when you look closer, you can see that the implant here is completely worn, metal on metal. And these two screws are actually still in place. And the screw that had displaced into the front of the elbow was actually from the ulnar bearing. So they're in place. And then this required osteotomy to remove the ulnar component. One thing we found with the discovery implant is the ulna integrates extremely well and often need osteotomy to remove the primary implant. And this is what it looked like on the post-op x-rays. Okay, two-stage revision. So two-stage revision mainly for infection. And again, you do these for infected total elbow replacements which don't fit the criteria for performing a DARE procedure. If it does fit the criteria for a one-stage revision where you don't think there's any infection, but there's both component loosening, then you need to be really suspicious that there may be an infection. With significant bone loss, you might need to do this as a two-stage procedure, and also with poor soft tissues to make sure that you're going to get good soft tissue coverage of the implant following revision. Again, the procedure is the same. It's a thorough debridement. You may need to create osteotomy, bone windows to remove the implants and the cement membrane, but you have to remove all the cement and all the membrane because if it's infected, if you leave any of that in, there's a significant risk of it becoming reinfected. Again, tissue samples as before and antibiotic-loaded cement spacers. We use Copal cement and add in vancomycin as required. So, and a debridement can often look like this. And this is just from the humeral part of the previous implant. So you remove the humeral implant there together with the bone involved in the periprosthetic fracture and lots of soft tissue. Post-operatively, if the soft tissue is not very good, put them in a splint until the wound is healed. IV antibiotics where there's significant soft tissue involvement, and discuss the culture with the microbiologist, monitor with white cell count, ESR and CRP, and repeat the first stage if you're still worried there is persistent infection. There's nothing wrong with having to go back in. So the second stage, this is the reimplantation of a new implant, a minimum of 3 months after the first stage. You need to make sure that the white cell count and the inflammatory markers are normalizing. Sometimes in the inflammatory arthropathy patients, you may not get back to completely normal inflammatory markers, but they need to be stable. If there's any clinical evidence of infection, you need to do a re-debridement. And we don't, in Sheffield, do a routine reaspiration unless we're suspicious that there's significant infection persisting. So the second stage, again, theatre time is crucial. Personnel are crucial. You need to make sure you have the implants, and sometimes these are custom made, and I'll show you a couple of these in a minute. Bone grafts. Some hospitals routinely have a bone bank where they have quick access to struts of bone, but unfortunately in many places these have to be ordered beforehand, especially when you're considering doing significant allograft. This often needs to be harvested, and to my knowledge this isn't routinely done with organ donors. So you need to put in a request with the local donation service, and they will then take that bone for you. Always send tissue samples during the second stage as well. So here you can see again a similar picture to what Dr. Stanley showed earlier on, with the humeral component moving, with the stem moving anteriorly. This was obviously infected and underwent a first stage revision initially. For those of you that are looking at this very carefully, you can see on that right hand x-ray, there's a little bit of air there. So this lady, she came out, she took the splint off, and when she flexed her elbow, she decided that she could try and use her arm. And when she flexed, the spike of bone came through the vascularized flap that had been put on by the plastic surgeons. So we went back in and redid the debridement and performed again another first stage, but this time putting some wires in which were connected and then surrounded by cement. So that linkage, I put cement around that also to try and give her a little bit of stability in her splint. And that's her second stage revision. Then you get other cases like this where there's been significant bone loss. This is a non-union, a periprosthetic fracture non-union. This lady has had this fracture for many years and now had decompensated, in that initially she was coping wearing a sling, but got to the stage where she couldn't do that anymore. And for this lady, we took out the distal part of the humerus, as you can see here. And something I didn't appreciate was the degree of HO that she had, with a massive spike of bone on the lateral side. So we had to remove this, and fortunate enough to say that her nerves all still worked afterwards. We did a first stage just for the humeral component, as the ulna was well fixed and there wasn't any evidence of infection. And later on, she went on to have this implant put in. There is one comment I would make about this type of implant is, given the forces that are put through and the torsional forces that are put through, the interface between the implant and the host bone, they can get loose. And people have found this lady's okay up to now, but I fully expect that this may well get loose in the future. And again, one of the cases left to me courtesy of Dr. Stanley when he retired was this lady who had numerous revisions of her elbow replacement over the years. I think when she told me she had 20 odd operations on this elbow. We made sure there was no infection in this. We took out the implant that you see there. She already had a shortened humerus due to her previous revisions, and already had an allograft attempted, which unfortunately hadn't healed. So we took all the bits out, and she ended up having a custom-made total humeral replacement. Again, this is obviously limb salvage type surgery, and very rarely performed. I have done 3 of these now, and this one's doing well. I have had one where the shoulder, the hemiarthroplasty, is dislocating anteriorly, although she doesn't have any pain. And the third one I did about 2 months ago for, I think it was her 4th revision. So, but these are very rare, and obviously shouldn't be attempted unless it's absolutely the last resort. Excision arthroplasty we've mentioned, and sometimes after the first stage where you put cement balls and spacers in, patients don't want anything else doing. And again, that is completely reasonable. If they can live their life in a lightweight splint and are happy to use their hand in the position the splint keeps them in, then leave it at that. This patient I expected fully to want further surgery, but following the first stage revision, using the long sausage of cement, I should call it, and the wire into the ulna, he didn't want anything else doing. And to this day, this was, I think, about 6-7 years ago, and to this day hasn't come back. He may have gone somewhere else to have it done, but hasn't come back to me requesting that he has a second stage revision. So in summary, a DARE procedure can be undertaken with early diagnosis of infection and less than 3 weeks of the onset of symptoms. A single stage revision I would only carry out with aseptic loosening, unstable implants, and a two-stage revision for infected elbows not fitting the criteria for a DARE procedure, sometimes for aseptic loosening where the loosening involves both components, the significant bone loss or poor soft tissues. Thank you very much for that.
Yeah, thank you so much, Dr. Ali. That that was a wonderful talk, and they were very challenging cases, obviously, to deal with. So I think we'll have some discussion on this. I'd request everybody to unmute, and we can have some questions. Yeah, we can have some questions or comments from the panelists. Yeah, Dr. Pradhan.
Yes, that was an excellent session, Warid. Thank you so much. Thank you, Professor Stanley, Shantanu, and Dr. Amjad Ali also. Shantanu, I want to ask you a question. So what is the earliest age at which you will consider doing a replacement in trauma?
So that's a difficult question. So the youngest I have done is a 59-year-old lady, but this lady was physiologically much younger, and she had one of those X-rays that I showed, where the distal humerus, as if a bomb had exploded under it. And I just said that I could try and fix it. It'll be a bad fixation. Then I will leave it in plaster for 2 months because I'm scared to move it. She'll have a stiff elbow. It will then fall apart. Then I will do an elbow replacement. Second operation, it'll get infected and so on. So I did it. It was not the ideal patient. She was quite fat. She had diabetes, but she lived on her own, and this was her elbow. It is now 7 years and she's still okay. But I say normally above 70 in a physiologically okay patient, 65 is stretching it. Above 75, 80, I have no hesitation whatsoever because it will last a good 8-10 years. David, Amjad, you both agree with that?
Yeah, I think the other thing to consider, Shantanu, is, you know, we've started doing some hemiarthroplasties for distal fractures, but I think the indication for doing hemiarthroplasty to me are small. I know there are other surgeons in the UK who do a lot more than I do, but I think for that age group in the late 50s and 60s who have a very comminuted distal humeral fracture where reconstruction looks impossible on the CT scan, I think now I would have a hemiarthroplasty set on standby. I would look in from both sides of the triceps, see what the fragments are like, and leaving the triceps on, I would do a hemiarthroplasty and reconstruct the ligaments or the condyles onto the hemiarthroplasty. And I think that has served me well over, I've only done a handful of those, but all of them seem to be doing well. They do get a bit stiff, but I think rather than doing a total elbow replacement for them in that age group with, you know, high functional demand, I think it is a kind of halfway house really between the two without the complications of the total elbow.
Chetan, I would ask you to read Greg Bain's papers on that because he started doing some hemiarthroplasties from Australia, and it is a new advance. I can tell you, and Amjad will vouch probably, and David will, that I don't think the results are anything like a total elbow replacement, because the results of total elbow replacement in the right patient after trauma are phenomenal. Absolutely, you have transformed their life, and they get very good movements. They have these implications of what they can't and can do. But hemiarthroplasty, from reading the literature, it's not as satisfying, but nevertheless is a bailout.
Thank you.
I think the other thing is that, of course, elbow replacements for trauma, the patient only has, or usually only has, one problem joint. That's the elbow they've smashed up. So once you give them an elbow replacement and their pain is taken away and their elbow movements are restored, they do tend to forget the limitations that you tell them that they shouldn't do more than lifting and, you know, relatively light weights. So I think you have to stress to them, if they're otherwise fit and well, you have to stress to them that if they have an elbow replacement, they ought to, you want that elbow to last as long as they do. They don't need to come back again needing a revision. So that's the only thing I would say to them.
Thank you.
Dr. Gautam, you have any question?
I have a comment on Chetan's question.
Yeah.
Chetan, obviously the population in the UK, the population in India is completely different. We are dealing with a different beast altogether.
Right.
To give you a simple example, life expectancy in UK is 84 for females, and life expectancy in India is 72 for females. So I think absolute numbers are probably not going to give us the same kind of comparison. However, a simple thing is you look at their physiological age. If you feel they are 55 but a wreck, they have a smashed elbow but they are looking after themselves, they are alone. Indian females do a lot of household work.
Yeah.
They are kind of the root of the family. I would not hesitate to offer them an elbow because I know that if we don't, the family goes into a wreck, which is, so our decision making is going to be a little different from what I have been trained to do, and it is an eye opener because you kind of see things from different side of the world and completely different things.
Yeah, I would agree. I would agree with that. That makes a lot of sense, really. I mean, it's not the actual age; it's really the sort of the physiological age of the patient. So, if your patient population average life expectancy is maybe 10 years lower than in the UK, then of course you have the facility to do an elbow replacement in someone a bit younger than we might choose.
Right. Thank you.
I have one question regarding the approach. So what is the commonly done approach? Like, for example, we are doing for a rheumatoid, maybe 60, 70 years old female. So what will be the preferable approach?
I can tell you about the approach me and David Stanley designed. Amjad can tell you if he has modified it a little bit. So we do a triceps splitting approach, which combines triceps reflecting. So we basically go through the triceps very close to the ulnar nerve. So we leave about 1/4 of the triceps with the ulnar nerve and reflect that bit of triceps medially, taking the bed of vascularity of the ulnar nerve with it. Does that make sense?
Right.
And then the lateral 2/3 of the triceps, or lateral 3/4 of the triceps, is reflected laterally over the olecranon process on the lateral direction. So what it does, once you've done that throughout the operation, the one big worry I always have, and I always still continue to have, am I damaging the ulnar nerve? And we have stopped putting ligatures around it because the ulnar nerve's vascularity, as you well know, is very tenuous, and it comes as end arteries, and it's not the same as the remaining nerves. And therefore, this 1/4 or 1/3 piece of triceps protects the ulnar nerve, and the remaining is reflected out. So you get a tricep split approach, but you get the advantages of reflecting approach. Now, if you have done an unlinked elbow, then you want to provide some stability at the end of it. And therefore, you can suture these two parts of triceps together and get the stability. So if you feel, oh, the ligaments are all gone in a rheumatoid lady, I better make this a little on the tighter side. You can just make the tricep suture better. So it combines the two advantages. It protects the ulnar nerve, and you drill holes in the olecranon and then suture the tricep back. I cannot last remember having a triceps dehiscence as my problem. But this is the approach me and David have always used. I don't know, Amjad, if you have modified it or anything different.
No, I haven't modified it. I was just actually flicking through my talks because I presented the approach, maybe more of a triceps in the midline reflection, but I had a little video of it, but I don't know if I'll get that up or not, but it's I still use that. I know people are popularizing the triceps on approach, which I think is very good, which you can use for primary arthroplasty. I don't think it's suitable for revision. But people report very good results with the triceps on. But I think it's probably worth going on to that when you have more experience with elbow replacement, because often the problem is gaining access to the ulna and problems with malpositioning of the ulnar component, trying to leave the triceps on. But I think with the Shani Stanley approach that's been described, it's very easy to get good position of both implants. So
Just a quick comment on what Amjad just said. Use in the early days, whoever is listening to this, use approach which gives you good exposure. There is no point in sparing the triceps if you actually put the implants wrong, because you have tried to minimize this fad of many open techniques where you actually do a bad operation, but you've got an incision 2 inches long, is absolutely useless. You have two operations in orthopedics. You have either an arthroscopic approach or you have an open approach. When you open it properly. Don't try and do this 2 incision here and 2 centimeters there. And secondly, the only take-home message is don't do an olecranon osteotomy approach for elbow replacement, as I've told you. It is not the right thing to do. And therefore, take a decision before you go for surgery, what you're going to do.
Do you want me to show the video, or are you happy to show a very quick clip or not?
I think Dr. Parag has a comment to make, and then we'll go for the video.
Let us see the video first.
Right. Okay. You can share your screen and we can quickly see that video.
Okay, I will share my screen. 1 second. If I can get to it, there we are, share screen. There we are. So if I just press that. So this is just on a PowerPoint slide, and hopefully this is the end of it. So just to summarize the approach. So that's the ulnar nerve I'm pointing out there, and this triceps has just been split down the middle, all the way down, and reflected completely off the medial and lateral sides, subperiosteally off the ulnar. And then you take the whole envelope on the lateral side, all the way around, detaching the ligaments and the common extensors. And again, on the medial side, you leave the ulnar nerve in its bed. You reflect underneath the ulnar nerve and the common flexors, and then dislocate the elbow. And then you've got a great view of the humerus and the proximal ulnar. Your incision doesn't have to be as big as on that demonstration, because some people get scared by the size of the incision for the elbow replacement. And then when you close it back up, you can flick everything back round, and the ulnar nerve lies behind the medial epicondyle again, and you reattach the triceps back onto the olecranon, usually with non-absorbable suture through drill holes to make sure you get a good footprint, and then close everything back up.
Thanks, Amjad. That was very useful. The only thing is our approach was the original approach was just slightly more medial incision in the triceps.
Exactly.
Yeah, that was wonderful. So you just incise the triceps in the middle and take a sleeve, a periosteal sleeve kind of a thing on the other side.
Yes.
Yeah, right. Yeah,
I think the people who transpose the ulnar nerve, one of the things that so often you see in textbooks and in operations is that people start putting slings around the ulnar nerve so that they know where the ulnar nerve is. And then they attach a clip to the sling. So there is pressure on the ulnar nerve whilst they're doing the operation. And I think that is why probably they see a high-ish incidence of neurological problems with the ulnar nerve. In the approach that Amjad's just shown you, literally you can get right round, but you leave the ulnar nerve where it should be. And every time you flex and extend your elbow, the ulnar nerve glides on its base about 7 millimeters. So once you start to devascularize the ulnar nerve and take it out of its bed, then you potentially are introducing not only a problem with the blood supply, but also a problem with the ease with which the ulnar nerve moves and increase the risk of it being scarred up. So I've always tried to avoid transposing. Now, if I've got a primary ulnar nerve problem, then I may transpose, but I would always tend to just do a superficial decompression rather than transpose. But I think in a situation where the ulnar nerve has been functioning normally, but you just want exposure, then I think that is a better approach by just protecting it as much as you can with its soft tissues.
Just to slightly deviate, Warid, the only two indications excluding elbow replacement when I transpose the ulnar nerve and not just decompress it is, number one, is subluxing ulnar nerve. Subluxing ulnar nerve with ulnar neuritis is a very good absolute indication. And the second one, which I've started doing since joining Sheffield Children's Hospital, is a cubitus valgus deformity. So if you have a lateral epicondylar non-union and the elbow has gone into cubitus valgus, even after you have corrected that, the length of the ulnar nerve itself is long. And so those are the two good absolute indications for transposition. But otherwise, I really don't like transposition. The way you destroy the vascularity in transposing, people don't take out the arcade of Struthers, they don't do adequate os bones ligaments, and they have this big kink that comes in the ulnar nerve, which is actually worse than before. It has to be transposed over a long length. And then again, people get into all kinds of problems, subcutaneous transposition, submuscular transposition, and so on. So the best thing is not to transpose it unless it is subluxing or there is a deformity in the elbow. I hope that helps.
Absolutely. Yeah. Point taken.
Parag, you had something to ask?
Yes, I had a question to Professor Stanley. And I'm not a very much elbow guy. I don't do much upper limb, but I've been always hearing about the so-called partial elbow replacement. So maybe the radiocapitular or ulnohumeral. So what's the role, Professor Stanley, of these so-called partial elbow replacements, and should we try and do them at all? And what are the indications, if any?
Yeah, I have never used one. So that the radiocapitellar joint replacements, I think Joe Pooley in Newcastle was the first to introduce it, and then Dr. Mori produced his variation on it. I think if you look at the situations where it may be valuable, it's really only in degenerative arthritis, which is traditionally, when you look at an elbow that's becoming degeneratively arthritic, the process always starts on the radiocapitellar side of the joint. And the ulnar trochlear aspect of the joint is often well preserved until much later in the process. And that's something that not only I have seen, but other people have seen as well. So you're trying to replace it to make that side of the joint better. And I think that it is technically difficult as far as I can see, because I've seen x-rays which none of them seem to be quite the same. So the idea of trying to actually do it, I think it can be technically difficult. And I know that Joe Pooley sometimes replaced the capitellum, but didn't do anything about the radial head. And then you can also argue, of course, that in the UK, going back 30 years or so, problems with the radiocapitellar joint were often dealt with by removing the radial head. That's a cheap operation and it's a simple operation. And in some people, it still works, because throughout my career, I don't think I saw anyone who came back having had a radial head excision in a degenerative arthritic situation. You do see people who've had a radial head excision in rheumatoid who come back because the whole of the elbow is degenerating. But I have to say, I'm not sure in my own mind whether a radiocapitellar joint replacement is worth the money you spend on it, except perhaps in a very select group, small group of patients.
Okay. Yeah, Shantanu, a quick question for you. So, what is the general average lifetime of an elbow replacement? If a well-done elbow replacement should see the patient how many years through?
You mean in a trauma or in an elective?
No, in an arthritic elbow.
So to me, I can quote you some figures, but they'll be different. But in the rheumatoid, they last longer. And as David and Amjad were both alluding to, their requirements in life are less. So they have crippled hips and crippled knees, and they generally potter about the house. And therefore, you do an elbow replacement. Therefore, I have no lower limit for a rheumatoid arthritis replacement patient. That was taught to me by David.
But how long?
Sorry, you were saying something. Sorry?
How long does an elbow replacement?
So I would give it at least an 80 to 85% survival rate at 10 years.
10 years.
At least.
So, like
probably better.
When I do a total knee, I see a patient that it'll last you about 20 years, 15 to 20 years.
Yes.
So what do you tell your patient when they ask you how long will this elbow last in a very averagely arthritic elbow?
10 years.
Yeah.
That's
I mean, I think we've looked at the length of time. We've got minimum 10-year results.
Okay.
But that's again in the rheumatoid population. And I mentioned earlier that if you're doing elbow replacements in trauma, because the patient thinks they're pretty normal, they're likely to do some crazy things. And if they do crazy things, it will loosen and cause a problem much sooner. But I think it was, I was trying to remember, but I think it was a paper from Dr. Mori from the Mayo Clinic, where they reviewed a group of patients who'd had their elbow replacements for 30 years. Now, that will be a fairly selective group of patients, because some of them will have died. So you don't know, you don't really know how many are going to survive for 30 years. And we all know that when we do any procedure, some patients seem to do exceedingly well and they don't show any signs of loosening or any complications. And other patients where the same operation's been done seem not to do anywhere near as well. So I don't think necessarily you could ever say to a patient that your elbow replacement we would expect to last for 30 years, but I think at least a 10-year and probably more would be reasonable if they don't develop any complications.
I think the only ones anecdotally, I can't give you any figures, but anecdotally, the problems I've had post-primary elbow replacements are in patients where I've in a way reluctantly performed the total elbow replacement for osteoarthritis. And I don't think they do as well, because I think they can go back to living a completely normal life with their arthroplasty, whereas the rheumatoid inflammatory arthropathy patients appreciate the limitations more. So I think for osteoarthritis, it's probably not as good as the inflammatory arthropathies.
And golf is a very big thing in the UK, Parag. Golf is such a big thing. Every retiree wants to go and play golf. Mm-hmm. And that is a big issue, because the amount of strength, if you've played golf, you will realize when you take a driver 1 or 2 and hit the first shot, I dread to think what happens to that elbow replacement.
Yeah, so just a quick follow-up question to the same answer of 10 years. So in a lower limb, which is a weight-bearing joint and which is more abused, so to say, life is 20 years, and in hips, maybe more. So what's the mechanism of failure in elbows that makes it fail in 10 years, 15 years? So even though it's a non-weight bearing joint, this is just a...
Can I come in there first?
Yeah.
My opinion, again, I don't have any biomechanical studies to prove this, but again, anecdotally, it's the torsional force on the arm. So if you imagine a knee replacement, a hip replacement are weight bearing, and the forces going through the joint and the cement bone interface or implant bone interface are compressive forces. Whereas in a lot of elbow replacement, where you have very poor soft tissues anyway, and generally in the inflammatory arthropathies, poor stability of the joint, a lot of the force, a lot of the time in a patient's life are distraction forces and torsional forces. So anything you do with your arm, with it up here, there's always going to be a torsional force on the humeral stem, and also a distracting force with the arm by your side. So I think, in my opinion, that's why they fail.
I don't know if design issue. If probably better designs come, do you think the life would be longer?
I'm not sure, really. I'm not sure, because I think it's all about the torsion and the distraction. So unless someone comes up with an invention which stops that or minimizes that, I think the problems will always be there. And I think that's why meticulous surgery, meticulous technique at the stage of the primary implant helps with that. With good cementing techniques, the flange to try and stop the flexion, extension and the torsion on the humerus as well. David, I think you probably want to come in.
I think as well, in contrast to the knee, the elbow, of course, has flexion and extension and significant pronation and supination movements. And some people have tried, when a revision's been necessary, to put the ulnar component into the radius because the ulnar has been so poor, and they invariably fail very, very quickly. So that's a no-no, really. And I think everyone talks about the elbow as being a non-weight bearing joint. Well, it is sort of a non-weight bearing joint, but the forces, if you pick a box up from the ground, you clamp your hands to the side of it to lift it up. And the force that you generate in that process of compressing the object you're trying to lift up and then lifting it up can be, again, about 3 times body weight. So the forces can be fairly significant in a joint that's relatively small. So I agree entirely with what Amjid said, that it's a mixture of torsional forces, and just the different character of the elbow joint to the knee, really, or the hip.
Just a simple addition to that, Parag. The forces in the lower limb, a large number of them are dissipated by large muscles around it also. And the surface area is quite large in a tibia or a femur. Whereas you have a really tiny amount of surface area in the elbows. If you look at the ulnohumeral replaced joint, it's a few square centimeters, if at all. And the muscles are not as big. And finally, coming to the implant design, we have tried all of implants, and we have finally gone back to Kundan-Mori, which was one of the first implants that came out. And it's a linked implant, and relatively for an elbow surgeon, and Gautam, when he starts doing them by the hundreds in India, he will tell you that that is, once you get good at it, it is actually the easiest implant to use. Because the stability of the implant, which is one of the big complications that David Stanley showed, is eliminated by the flange in the middle. So your exposure becomes easy, because you can take out all the ligaments, you can take out the common extensors, because the implant is giving the stability. The reason kudos started failing, I think, at least in my early hands, is I was worried about not exposing it properly because I wanted post-operative stability. So I wasn't getting a good exposure. And in then trying not to do that, implants were not being placed properly. And I said, why am I doing this crazy operation? Let's take the whole thing down and put in a linked implant. So I think the linked implants are here to stay. And as Amjad said very clearly, I don't think we will get a phenomenal, I don't think we will have a 30-year Chande results in elbow other than for a select group of people.
Okay.
Question to Mr. Ali, Mr. Stanley. The Conrad Mora is coming with a 2nd generation elbow. They have changed their links because I think that was the weak link, the bearings or the bushings. And they are now very similar to Discovery bearings. So I don't know if there is experience across, because we don't have that in India. And I don't see it coming for the next few years anyways. But the early results, I don't know. I don't know really what the results are like.
I don't know if there are already studies looking at the Nexel alone. That's what you're referring to, is the next generation Conrad-Mori implant. And you're right, it essentially, to me, being a simple person, it's a hybrid between a Discovery and a Conrad-Mori to increase the poly, I think, more than anything else, because the poly in the Conrad-Mori is very small. But I don't think, without the longer term results, you can't really compare them yet. And I certainly haven't moved on to the Nexel, because I find the Conrad-Mori such a, I say, easy implant to use, such a simple implant to use, and has good longer term follow-up and survival rates. And I think given that most of my practice at the moment, rather than doing primaries, is revisions, for revisions, it's an ideal implant to use because it's linked, it's simple to use, and it comes with the various options. Occasionally you need to get the custom made ones, but I think given the simplicity of the implant, when you're doing a 5-6 hour operation, what you want is a simple implant. You don't want to be fiddling around putting in bearings partway through the operation.
I mean, I did a few discoveries at Derby, and yes, it is a fiddle to get those bearings right. But if I look pure literature, Discovery certainly outperforms Conrad in terms of whatever equivalent. So if we compare apples to apples, then the outcomes of discoveries are better than outcomes of Conrad for the same length of time.
Yeah.
So Prof. Prostrate certainly got something right in that design.
I think it's whatever you're comfortable with. If you're using an implant, you're used to it, you'll do the best possible and you'll use the best technique for it. So I think the wrong thing to do is mix and match implants all the time and do lots of different ones. I think get used to one and use that implant.
Yeah.
Just a little technical tip. When you've got to the stage of putting your trial implant in, so you've got your trial implant in the ulnar and the humerus, if you gently flex and extend the elbow and one of the two implants moves significantly.
Pistons, you mean, yeah.
Yeah, pistoning. If that happens, then you need to re-look at why that's happening. Because if that's happening just under passive movement, even when the implant is cemented in place, those forces are still going to be there. And they, I think, will lead to early loosening occurring. So try and get the whole thing balanced before you actually cement it in place. I think that's quite useful and quite important.
Yeah.
So I have one last question from my side to Dr. Gautam. So Gautam, what are the reasons why elbow replacement hasn't really picked up in India, apart from the costs and the expertise available? Of course, those two things are known factors, but apart from these two factors, why hasn't it really picked up? What's your take on that?
I think, Dr. Sanjay, I'll be very honest, and I think the honesty is we are still struggling, or we've just got doing acceptance to knees and hips. If you look at the history, Chanley started off with hips, the elbows came a lot, I think 2 decades later. I think it'd be a lot to do with more education and westernization. I think you've got to get our basics. Let's get people walking about first before getting them a little concerned about upper limb, because I think the same happens to the shoulder. We don't do as many shoulders as it's done in the Western world. So it's more to do with necessities, really.
But
yeah, and associated with that, if someone needs an elbow replacement but they need a hip replacement, then the hip replacement should be done first, because if you do it the other way round and you do the elbow first, then they have their hip replacement and they're using crutches to get going or sticks.
Then we ask Dr. Ali to come.
They're going to loosen their elbow replacement. So it should always be lower limb before upper limb, I think.
This is very, very important for people who are live on this thing. Our philosophy has always been lower limbs first, upper limbs next. In lower limb, go from proximal to distal if you can help it. And in upper limbs, again, go proximal to distal if you can help it. Because what you don't want, and once it happened, and I got a remote call, the surgeon was doing an elbow replacement and never, ever examined the shoulder. And he could not get the patient in a lateral decubitus position because the shoulder was ankylosed at 30 degrees of flexion. So he just could not get the arm across. And the arm was here. They woke the patient up because he had never examined the shoulder. He needed a shoulder replacement first before the elbow replacement. And that's what we do hips for. So this is our lower limb first, then upper limb, and go proximal to distal, in rheumatoid especially.
And one other thing just to add into that is if the person has got an absolutely useless hand for some reason, then what is the point of making their arm move any better? So in many ways, you're really doing an elbow replacement. If that's your operation that you're doing it to try and make the function of the hand better than it was, so they can use the hand. Yeah, so they can use the hand. So it may be sometimes that you think, well, this person's got a really poor functioning hand and a poor functioning elbow. And as Shantanu says, get a hand surgeon to see if there's anything that can be positively done to improve hand function, maybe before the elbow.
David, I'm pleased you mentioned that, because that X-ray I showed with the long sausage of cement in the gentleman who didn't want anything else doing, his comment to me was, my hand doesn't work at all because it was very deformed, couldn't move his fingers. And he said, what's the point you doing my elbow if I can't even use my hand? And that's what he said. And that's what his reason was for not having anything else done. So thank you for that.
Yeah, I think we have generated a very, very good discussion in the end. And I would sincerely like to thank all the speakers, Dr. Stanley, Dr. Ali, Dr. Shahane, and the panelists, Dr. Pradhan, Dr. Tavri, and last but not the least, Dr. Parag Sancheti, and of course, Dr. Ashok Sham. I think he's there around. Without his effort, this would have not been possible. And I think hundreds of viewers are already there watching this. And I would sincerely like to thank all of you.
Can I just say thank you from our side also, firstly to Parag for approaching me and all of your faculty. But from the UK faculty, I want to give special thanks to David, Stanley and Amjad. They have prepared excellent lectures in a very short space of time at my request. They never have let me down ever. So thank you both of you, and thank you all of you, and have a good night's sleep.
Thank you.
Yeah, thank you very much indeed. It's been a pleasure to be with you.
Thank you.
Thank you, Mr. Stanley. Thank you, Mr. Ali. Thank you, Mr. Shahane.
Thank you.